So hello, thanks for joining us today. As you can see by the title, this is quite tantalizing, quite provocative. Golly, preventing, and wait for it, reversing cognitive decline. These are dramatic statements, and let's go directly to the source. These presentations are taken from work done by Dr. Dale Bredesen. He's a board-certified neurologist working at the University of California in Los Angeles, and he's recently published a book. I'm told it's on the New York Times bestseller list, and the title is quite simply The End of Alzheimer's Disease. So the parts that you'll hear today are taken from Dr. Bredesen's book, and you'll notice on the right-hand side of this slide, this presentation was initially created by one of Dr. Bredesen's trainees, physician assistant Meg McElroy out of Austin, Texas. So we want to give credit where credit's due. But clearly this title grabs us. It's very tantalizing. And you know, this is the Holy Grail, isn't it? When you get right down to it, can we prevent and reverse cognitive decline? Let me kind of give you Dr. Bredesen's premise. I like it because it's certainly a dramatic change in thinking. We're a very pill-oriented, pharmacocentric society and culture, and even Western medicine is in that direction. Think of pneumococcal pneumonia, you know, a dreadful lung disease that's a very specific disease, has a very specific cause, and it's treated very successfully with a single medicine. Not pneumonia, forgive me, an antibiotic, penicillin. So for the longest time now, looking at cognitive decline, we've kind of had a similar target. You know, is cognitive decline, does it have a single cause or maybe one or two causes or contributions that we can directly attack with a single medicine and therefore reverse it like we do with penicillin and pneumococcal pneumonia? Well, Dr. Bredesen holds that it hasn't been productive, perhaps it's even been futile, to look for a silver bullet. So his notion, and I like the language, is he's all about looking for silver buckshot, that cognitive decline doesn't have a single cause like the single bacteria in pneumococcal pneumonia, but it has many causes, many contributors, and that we need to address all of those simultaneously and over time in order to ideally prevent and reverse cognitive decline. So that's the mission statement. And you know, as hinted, there are so many factors and so many different diagnoses. You know, last week was exciting in the world of Alzheimer's dementia because a paper was published that suggested that perhaps Alzheimer's dementia has a viral cause, that exposure to certain viruses when we're very young, these viruses are dormant and may contribute to cognitive decline as we age. So there's now this, yet again, another possible factor, another cause or contributor to Alzheimer's dementia. And as you, the audience, knows, we have multiple dementing diagnoses. Alzheimer's dementia, we think, is the largest capture area and the most common, but we also recognize that there's a vascular dementia, there's a Lewy body dementia, a frontotemporal dementia, and the list goes on. chronic traumatic encephalopathy is a type of dementia. We certainly hear about that in the news. So many factors, so many different diagnoses. It's perhaps too simplistic to imagine that there's going to be a single drug that's going to be helpful given these many different diagnoses. And in fact, this is the dazzling array of causes and contributions to cognitive decline. I counted these up last night. There's 17 on the board here, and you'll notice they're color-coded, although it's not crystal clear what the coding's all about, but you'll also notice there's stars to indicate the, quote, most common causes of this non-specific cognitive decline. But let's start at the 12 o'clock area, and we'll kind of rotate around. This is exciting now, particularly in Alzheimer's dementia, that perhaps as we age, our sleep patterns change, or sleep architecture changes, and there's evidence that's accumulating now that if we can perhaps enhance a particular type of our sleep pattern at night, slow wave sleep, we may in fact clear beta amyloid protein. Hormonal imbalances. For the longest time, it's been a mystery why are elderly women far more likely than elderly men to have Alzheimer's dementia. And the question is there some sort of loss of hormonal protection due to the menopause? I think it's far more complicated than that. From the little I know, Dr. Bredesen talks about not only sex hormones playing a part in cognitive decline, but other hormones such as cortisol, the famous stress hormone, and pregnenolone, perhaps a protective hormone that declines as we age. Food intolerances, golly, I have to note that Dr. Bredesen, before he wrote The End of Alzheimer's, he wrote another bestseller 15 years ago called The Grain Drain, talking about gluten intolerances and their effect on our physiology. We know certainly from the blue zone studies that a sedentary lifestyle, an inactive lifestyle, appears to play an enormous part in cognitive decline. So the importance of staying physically active. Now, age and ROS, I made the mistake that what they're talking about here is age as in chronological age, something that's very fixed and not modifiable, and we certainly have evidence that as we age, cognitive decline becomes perhaps more apparent and more problematic, but age in this particular part of the slide stands for advanced glycogen end products, and ROS is an abbreviation for reactive oxygen species. Fancy medical lingo for problems with insulin resistance and insulin signaling, and reactive oxygen species are free radicals, which as we age become more prevalent in the central nervous system and we think destructive. And now at the 4 o'clock space, we've got glycotoxic type 2 diabetes. So there's really abundant evidence, particularly in Alzheimer's dementia, that as the disease progresses, our brain, which runs on glucose as its fuel, becomes, glucose metabolism becomes damaged, and insulin resistance rises. So again, a contributor to cognitive decline. You'll notice head trauma starred is very common. I mean, this in part comes from, now the studies looking at athletes, particularly NFL football players that in their mid-40s have severe dementing processes due to presumably head trauma, multiple head trauma, at an early age. Infections, this is something that a number of investigators have postulated, but it's difficult to find evidence for it. But as I said earlier, there's a new publication that looks like, herpetic asymptomatic infectious processes at a young age may play a part downstream in contributing to the development of Alzheimer's dementia. Antigens and allergens, you'll have to forgive me, this is a weak area for me, but Dr. Bredesen holds that perhaps there's a multiplicity of allergens in our modern environment that contribute to cognitive decline, and that kind of easily segues over to man-made chemicals. For the longest time, there's been strong evidence that Parkinson's disease is linked to early exposure to pesticides, particularly farmers, folks that live in rural areas that use pesticides have a much higher incidence of Parkinson's disease, and there's certainly Parkinson's dementia. But this goes beyond that. Is there a contribution from perhaps mercury? We've long known that when folks have abrupt cognitive decline, physicians will order a heavy metal screen. We're actually looking for poisoning from lead, from arsenic, from thallium, from mercury. Biotoxin illnesses, again, I think it's best that I leave that one to Dr. Bredesen. And suboptimal nutrition. Again, we have the folks from the blue zones that lead primarily vegan diets. More and more evidence starts to accumulate that in our fast food culture with particularly saturated fats that these may be very damaging not only to our gut but to our central nervous system. And at the 9 o'clock position, the infamous gene, the APOE4 gene, and of course this is now widely available to all of us. For $100, we can give a saliva specimen to Ancestry and Me or 23andMe, and within 2 weeks they can give us a genotyping that at least hints at increased risk for this disease. It doesn't mean that it's a predetermined fate, but certainly in a higher risk category if someone has both copies of the E4 allele. And, as an aside, there's now a global network called the APOE4 Information website that's a collection of people that have both copies and that are working very assiduously to try to find ways to prevent or reverse cognitive decline. Poor gut health. This is a growing topic now in medicine, and again, one of my many weaknesses. But we're beginning to recognize this process called the microbiome, that in our gut we have hundreds of thousands of bacteria that protect us, and that if we have poor gut health, that protection is diminished. Stress, cortisol imbalances, we live in a society where stress is this all-encompassing, non-specific word. The original definition comes from a physiologist, Hans Selye, in the late 1950s, where he gave random electrical shocks to rats and followed their cortisol level, the famous cortisol hormone. And he noticed that, when they had unpredictable, painful stimuli, that their cortisol levels were absolutely off the chart, and this downstream affected their organs, their tissues. So, of course, this leads to an entire industry designed to how can we reduce stress. It's a part of life on this planet. How can we be resilient to stress? And then kind of closing this little clock here, mitochondrial impairment. These are the energy factories, if you will, in the cells, and there's increasing evidence that if these energy factories are damaged or dysfunctional, and we think this often happens from a misfolded protein, the tau proteins damage these mitochondria, so now our neurons have limited or declining fuel supplies to run, and it ultimately leads to neuronal death. And then last but not least, it's amazing, here we are, Western medicine, kind of obsessed with anatomy and physiology, but we're now realizing that despite how connected we are as a species with technology, we're discovering how lonely and isolated we are despite this connection, and the important part that plays in cognitive decline. So as you review these, you know, what are modifiable, what are fixed? The good news is that, you know, just a handful are fixed. Most of them are modifiable, and that's Dr. Bredesen's message here. Let's treat cognitive decline by addressing all of these causes, all of these contributors, as optimally as we can, and not just one arrow, but kind of continuous follow-on about all of these contributors to cognitive decline. So it's an ambitious process. He actually has a specific protocol entitled the Bredesen Protocol, and it goes under an acronym called RECODE, Reversing Cognitive Decline. So that's a lot to digest, a very busy, dense slide, but hopefully it gives us a kind of the direction and the destination, if you will. So if nothing else, what we may walk away from today is a new word, although I think it's a created word. So many of us, particularly as we age, are familiar with a diagnostic test called a colonoscopy. And of course, this is where a gastroenterologist uses a very tiny articulated scope to visualize the internal workings of our colon. So we're going to create a new word here, a cognoscopy. We're not going to use a scope, but you're going to use a combination of tests to look at cognition. And of course, that word sort of takes us aback. What is cognition? It's a lot of things, or we can maybe boil it down to, I always call it the big four, the fab four, if you will. So cognition is information processing speed, attention, memory, and executive function. A cognoscopy is the combination of blood tests, genetic tests, simple online cognitive assessment, that's coming, although right now it's usually paper and pencil, and then a magnetic resonance imaging, but a very specific one where we look at sections of the brain and volumes of the brain, because we know with the cognitive decline we see volume loss, we see blood vascular changes, and these clues, this is like assembling a jigsaw puzzle. We take each one of these pieces to contribute to what is the cause or causes of cognitive decline, and where are you, the patient, at risk for it at this particular time in your life. So this is cognoscopy. And it begins, like any diagnosis, with a thorough medical history. And this is just the gathering of information from the patient, and ideally with their partner, their caregiver, their spouse, their adult child. And this is a partial piece, but this is just history. Has the patient suffered lifelong from a chronic inflammatory process of their sinuses that may have played a part in terms of inflammation of the central nervous system? Do they have any history of head trauma? And I always ask, not just head trauma, but head trauma with loss of consciousness. All of us probably bumped our head on a low-hanging door jamb, but we didn't have loss of consciousness. There's abundant evidence that loss of consciousness increases the risk for a variety of dementias. The use of alcohol. I mean, this is you boil alcohol down. It's a central nervous system depressant, and abuse of it, overuse of it, clearly there's a specific type of substance-related dementia that can partially resolve with long-standing abstinence, but there's also a point of no return. Oral health. My wife is a dentist, and she's educated me abundantly about very poor oral health, inflammation of the gingiva, inflammation of our pulp. This all seeds our gut, and in turn causes a kind of a generalized inflammatory process. Abundant evidence that poor oral health certainly affects cardiovascular health. General anesthesia. So this is very personal. When my father at 89 had fractured his hip, he underwent general anesthesia. I think it was probably the first time in his life. And of course, the orthopedic surgeon said the surgery was a success, but he never spoke after that. Wasn't able to rehab. I can't tell you how many patients I've seen with dementing processes that have, very long surgical histories and quite often, extended periods on heart-lung pumps and long periods of general anesthesia. We haven't quite put the pieces together, but we think this is a risk factor. Hormonal health. A huge debate years ago about the Women's Health Initiative. Is hormonal replacement therapy helpful, harmful, or inconclusive? But this is more exhaustive than that. This isn't necessarily just sex hormones, but a multitude of other hormones that we know contribute to our overall lifespan health. Sleep history. This is becoming more and more important, as I alluded to earlier, in terms of dementia research, but just in our society, there's this logarithmic increase now in sleep apnea, probably related to obesity. With obstructive sleep apnea, we have oxygen desaturation, so every night our brain is receiving less and less oxygen. So sleep history is crucial, and oftentimes referral to a sleep lab is diagnostic and leads to better treatment and better brain oxygenation. Exposure to toxins. It's not uncommon for clinicians, for someone with cognitive decline, to order a heavy metals screen. This is lead, thallium, arsenic, but other toxins as well, pollutants, mercury. I always ask veterans about exposure to Agent Orange. Common medications, so another new word there, a created word, dementogens, meaning a medication that appears to be associated with cognitive slowing. These are typically a class of medications called the anticholinergics. And they're very common. Benadryl is perhaps the best example. So here's an antihistamine to dry us out if we're suffering from, a runny nose. Here's this antihistamine that we use to help us fall asleep. But it's pretty clear that chronic use of anticholinergics has a downstream effect on slowing down cognition. And then diabetes. Here's this incredibly common illness. I think 30 million folks in the United States meet criteria for type 1 or type 2 diabetes. And again, if we think about cognitive decline being connected to problems with glucose metabolism and difficulty with insulin resistance, it's easy to see the connection. So part of the process for trying to sort out the causes for cognitive decline begins with simply your primary care doctor doing a thorough past medical history. We have some screening tools. JAMA is the Journal of the American Medical Association. This is obviously a bit dated, but in 2015 they talked about the best in-office short screening tools, not diagnostic, but they address directly cognition. So on the left is the mini-cog. This is a very brief, less than 5 minutes in-office evaluation where you simply ask the patient to remember word trial, and they get 3 attempts at mastering the word trial. Then you ask them to do a clock drawing test, and then you ask them to recall the initial word trial. So you're measuring immediate recall, clock drawing, which is actually very sophisticated for abstracting and sequencing and memory of what a clock looks like, and executive functioning, positioning of the numbers in the hands, and then delayed recall. So it gives us a score, and it allows us to kind of go or no go, cognitive decline or no cognitive decline. But it's very quick, and it's helpful for the clinician that has limited time. An improvement in cognitive screening is the MOCA. This is out of Canada, the Montreal Cognitive Assessment. This addresses language and visual, spatial, and more delayed recall, and also executive function. It takes a bit longer. It gives us a score for minimal cognitive impairment and then a score for dementia, and it's scored on a scale of 0 to 30. And then in England, this is an instrument that's thought to be most sensitive, most specific, but it takes quite a while to administer. It's 6 pages long. It's sort of a combination of the mini mental status exam and the MOCA, as well as some other testing items. So these are common screening tools that you would encounter when you're being assessed by a clinician for cognitive decline. Of equal importance, maybe greater importance, are the symptoms that the patient and or the family can describe for the clinician. So if you think about dementia as a generalized disease state, we have chronic memory impairment, and then we also have problems with recognition, with movement, with language, and the biggest area where we see problems are executive functioning, being able to plan, sequence, alter plans if there's a delay or distraction or a problem. You know, it's something we do automatically multiple times throughout the day. So we certainly want to ask the patient and the family, you know, what about memory? Is the patient having trouble recalling appointments, conversations, recent events? If they've watched a TV show, can they talk about it? Can they make small talk? And it's also assessing language. And then their ability to make decisions, you know. Some of this can be done through, you know, if you're locked out of your house, how would you get back in? If you find a stamped addressed envelope on the sidewalk, what would you do with it? But typically, this comes from the family in terms of driving, operating equipment, remote control a cell phone, a microwave? Are they able to do things they've done all their life? They've been the greatest cook. Now they start their famous recipe, but in mid-stride they walk off and it burns, okay? Losses in visual perception, I guess I'd also add losses in audio perception. Part of cognitive decline is making sure that the patient has the optimum in terms of hearing and vision, and those are also gargantuan tasks, you know, with macular degeneration and aging patients and glaucoma and almost the universal loss of high frequencies as we age. We've got wonderful interventions and treatments for those problems. And then, of course, if someone has problems with memory and attention and sequencing, decision-making is going to be incredibly problematic. Even decisions like, what do I wear for the day, or how do I brush my teeth, how do I toilet, how do I cut my food? And as this progresses, these losses progressive, as they progress, we start to see problems with, you know, poor judgment, impulsiveness. If I don't know what to do, then I panic. And perhaps I do something that's inappropriate or harmful. And then all that goes with that sort of loss that the patient experiences, this is suffering in its worst form. So the collateral history from the family and whatever history the patient can provide in terms of activities of daily living, you know, being able to use instruments of daily life, the basic activities of daily living, feeding, dressing, grooming, toileting, those are all part of the puzzle pieces that the clinician's assembling. Back to Western medicine for a wee bit, it's important that the clinician do a neurological exam to try to uncover whether or not there's a underlying neurological disease contributing to cognitive decline. Is a patient having Parkinson-like features? Do they have multiple sclerosis? Do they have difficulty with balance and walking? Blood work, this is simply the tip of the iceberg, but the usual suspects, a metabolic profile, complete blood count, thyroid functions, vitamin B12, vitamin D, heavy metals testing. These are all simply done. They're quite easily generally repaired, and they're part and parcel of the cognitive deficit workup. And then this is now standardized, an image of the brain. First off, ruling out major culprits. Is there a mass there? Is there an arteriovenous malformation? Are the blood vessels tangled? Is there evidence of an old stroke? And then the mental status testing that you saw earlier. So trying to kind of piece together, create this particular algorithm or protocol for what might be the causes and contributors to cognitive decline. And then coming into the conclusion here, kind of a breakthrough paper 2 years ago that perhaps instead of being zeroed in on amyloid protein burden as the major culprit and the leading edge of Alzheimer's dementia, perhaps there's another process afoot, and this is decreased blood flow to the brain. So this is an interesting proposal. The title at the bottom is very fancy, but some important adjectives. The early role of vascular, meaning blood flow, dysregulation in late onset Alzheimer's disease. And as you can see, there's a series of brain images. They're of different types. We'll kind of work right to left here. At the far right, that kind of old black and white picture, that's simply a magnetic resonance imaging. And it looks at tissue and volume. Tissues in the white and volume loss, or not volume loss, but the darker areas are ventricles with cerebral spinal fluid. And this is a, quote, normal image. And then as we kind of proceed to the left, we have a functional MRI, which looks at neuron uptake of different types of tracer ligands. And then in the middle, we're looking at blood flow in the brain. And then FDG, that's fluorodeoxyglucose PET, is a positron emission tomography. So we've kind of left magnetic resonance imaging at this point. And it actually looks at where the brain is actively taking up glucose. And then at the far left, this is a particular tracer that's been formulated by a pharmaceutical company to lock on to beta amyloid protein. And this is a particular compound, F18. It's known as amyvid. So these all allow us to kind of look at different areas of the brain and different functions of the brain, whether it's blood flow, glucose metabolism, or distribution of amyloid protein. They all have a different result. What's recommended now for clinicians is to order an MRI of the brain and ask for this very specific type of study called Neuro Quant, so neurological quantification, where we actually look at sections of the brain horizontally and vertically, and we zero in on different parts of the brain where we know Alzheimer's dementia kind of begins and how it flows, particularly in the hippocampal areas, and then to the parietal area, and then kind of heads backwards to the occipital area. This is more for clinicians than patients, if you will. And then the last slide, the neuropsychological evaluation. So we looked at some in-office cognitive tests. One is very short, 5 minutes, another is very long. But this is a gold standard. This is called neuropsychological evaluation. It's done by PhD psychologists. It's a battery of tests, typically 18 to 20 tests. They vary in length and in direction of testing. Some take 5 minutes, some take 30 minutes. Overall, it takes the patient about 4 to 6 hours to accomplish it. But it's a laser beam. It really identifies where the patient is at that point in time in terms of their strengths cognitively and their weaknesses cognitively. And as you can see, it breaks it down into very specific areas. But remember, right now we kind of hold that cognition is probably best defined by processing speed, by attention, by memory, and by executive function. But as you can see, neuropsychological evaluation gives you a much more detailed picture. So you take all these pieces and put them together, the history of the patient, the history of the family, their cognitive testing in the office, their blood testing, their genetic typing, their imaging, their neuropsychological evaluation, and hopefully we can kind of define what the major cause or causes of cognitive decline are, and then address them.